Thank you, Dr. Devan, and thank you all for inviting me. So, I have listed out the major vision-threatening complications that we often, not often, rarely face. So, what are the risk factors for suprachoroidal hemorrhage in adults? A sudden decompression in eyes with high preoperative intraocular pressure, hypotony during surgery, elderly age group, especially with uncontrolled systemic hypertension, high myopes, effects, and vitrectomized eyes. So prevention is better than cure in this situation. Preoperative intravenous mannitol administration is required if diopy is not controlled with other medications. Control of systemic hypertension. Stop anticoagulant use prior to the surgery. Stop antiplatelet drugs in high-risk cases. Adequate local anesthesia to prevent pressure on the eye. Avoid external pressure with the speculum. A gradual paracentesis to decompress the eye so that you don't get sudden hypotony from a high preoperative IOP. Use an AC maintainer, use pre-placed sutures. You can use viscoelastics in the AC to provide a tamponer and remove it at the end of the surgery if required. So these are the intraoperative features. You get positive pressure, that sinking feeling that you get when you see a persistent shallow anterior chamber, the iris and vitreous starts prolapsing. You see a change in the red glow as visible here, and a tense glow. So what do you do in this situation? Immediate wound closure is mandatory. It's better not to attempt anything else at this point in time. Intravenous mannitol if the patient is uncomfortable because of the elevated IOP. Avoid intraoperative drainage in order to prevent hypotony because then you establish a vicious cycle. It's better to take up these patients later. So postoperatively, control intraocular pressure with medications, use topical and systemic steroids. A serial ultrasound is required to look for clot lysis. When clot lysis occurs, then you proceed with surgical drainage. And this is usually done 10 to 14 days later. This is a demonstration of a surgical video by Dr. Pramod Bende, our vitreoretinal surgeon. Choroidal hemorrhages we usually leave to them, whereas choroidal detachments the glaucoma surgeon deals with. So here he's done a 360-degree penectomy, hooked up all the muscles, and then found the area of the highest elevation. And there the sclerotomy has been done, and you can see that the blood is being milked out with cotton sponges. And it's important to have either an AC maintainer or intraocular infusion to prevent hypotony during this procedure. Otherwise, the whole thing will continue. The second complication is malignant glaucoma, aqueous misdirection. And what happens here is you get some kind of surgical decompression, which usually occurs in eyes prone to this complication, like those with angle closure disease, though it can occur in open angle glaucomas as well. So you get shallowing of the anterior chamber with movement of the lens iris diaphragm forwards. The ciliary body rotates anteriorly, and you get a ciliary vitreous and lenticular block. If it's a pseudophacus, then it's a pseudophakic block. So the aqueous starts percolating into the vitreous cavity, and you get an aqueous lake in the vitreous cavity. So the whole thing again becomes a vicious cycle. Dr. Harry Quigley has come up with this theory of a choroidal expansion which occurs in susceptible eyes, which pushes the vitreous forward and then initiates these events. So these are the clinical characteristics: a flat anterior chamber seen here on a UBM, an absent PI or an imperforate PI, normal or raised IOP most of the time, but sometimes you can get a low IOP, anterior rotation of the ciliary body with supraciliary effusion. You have to rule out a cyclodialysis cleft or a choroidal detachment before you diagnose a malignant glaucoma. The ultrasound, you can see aqueous pockets in the vitreous. We start off with medical management. Cycloplegics are used to pull the lens iris diaphragm backward and to release the block, topical steroids, and aqueous suppressants. If you have a large peripheral iridectomy, then through that you can do a argon laser shrinkage of the ciliary process, or in a pseudophakic eye, a capsulotomy and an anterior hyalodotomy can be done. If that fails, this is a procedure described way back by Chandler, in which he started off with the paracentesis to form the anterior chamber. Then a sclerotomy was done about 3.5 millimeters from the limbus, about 3 millimeters in length. And if you had choroidal effusion draining out of this, then you knew that it was a choroidal detachment which was responsible for the shallow anterior chamber. And if it wasn't, then you go on to the next step, assume that it's the malignant glaucoma. So he introduced an 80 gauge needle with the hemostat to prevent it from going too posteriorly, and tap the aqueous from the vitreous cavity. However, this is a blind procedure and you can get vitreous traction with the consequent retinal detachment. So now we use automated vitrectomy instruments. So we have reported our cases of about 58 eyes in which required surgical management after the initial medical therapy. So first we initially tried pars plana lensectomy and vitrectomy. This went on to pars plana vitrectomy with acer formation pseudophakic eyes. Now in phakic eyes, we do phacoemulsification with a foldable IOL implantation with pars plana vitrectomy with a zonular hyalodotomy. Surprisingly, we had 6 cases with uveal effusion. So we always thought that choroidal detachment rules out a malignant glaucoma. But choroidal effusion can cause the entire thing to shallow and can precipitate a ciliovitreal block as well. So a choroidal effusion does not always rule out an aqueous misdirection. So we had a good intraocular pressure drop in all the 3 techniques at the end of the final follow-up. This is a surgical video. This was again done by Dr. Gopal and Dr. Vijaya. This was phacoemulsification done in eye with the malignant glaucoma with the persistent flat AC after surgery. It's difficult to do phacoemulsification, I agree. So sometimes we just do a little bit of a vitrectomy to soften the eye before the phacoemulsification is done. Following this and following implantation of a foldable IOL, you go on to a pars plana vitrectomy. This is to prevent the vitreous from prolapsing and blocking the opening which is created. So following the pars plana vitrectomy, the most important step we come to, which is you incise the anterior hyaloid face in an area where you have done the previous peripheral iridectomy. That is not possible. Then you go right to the periphery, create an iridectomy and bring the vitrectomy instrument into the anterior chamber. So this is what finally breaks the vicious cycle, a communication between the anterior chamber and the vitreous cavity, and this kind of condition usually does not recur again. This is the final step that is usually taken when all else fails. Wipeout is something which again we are very afraid of in patients with very advanced glaucoma with a macular split fixation. And these are some of the risk factors: older age, severe hypotony, and split fixation. It's important to note that the definition is a sudden idiopathic irreversible loss of central vision. So in cases where you cannot find out the cause. So we looked at patients with this kind of split fixation with a mean deviation from -25 to -30 decibels, really, really advanced glaucomas. And about 31 patients with combined cataract glaucoma surgery and 34 patients who underwent trabeculectomy were prospectively followed up. This is the kind of field loss that they had, very advanced, and this was the picture following glaucoma surgery. There was no loss of the central vision. None of our patients experienced a wipeout. The important thing to note is that these days we are able to detect the cause with swept source OCT. We can see folds caused by hypotony, maculopathy, and most of the time we are able to reverse whatever has taken place. Bleb infection is the most dreaded complication that we are always afraid of, and the most common cause is a wound leak. Rarely leads to such a bad picture with the Bleb infection and the hypopion and endophthalmitis. Most of the time it starts off in a mild manner. Ultrasound is done to look for vitreous exudates, but it's important to know what the risk factors are before you identify these cases. Use of antimetabolites for longer duration, extending to more than 3 minutes. Bleb leaks, use of contact lenses, inferior blebs. Almost 12% of inferior blebs develop infection. So I don't think anybody does this anymore. NLT block, surprisingly, is missed out in some of the patients who undergo a trabeculectomy. So it's very important to do a proper evaluation preoperatively. Continuous use of antibiotics is also not warranted. And if there are releasable sutures which are exposed, it's better to trim them rather than leave them hanging, inviting infection. These are the common organisms, especially in our scenario. Staphylococcus is very common. So you have to counsel the patient, avoid splashing water into the eye, avoid swimming, use protective goggles if you have to swim, use a protective shield at night if there's a very thin bleb, warn about early signs of blebitis and endophthalmitis, avoid using prophylactic antibiotics for long term, and avoid use of long-term topical steroids. So if it's blebitis alone with just bleb infection, very minimal cells in the anterior chamber, topical antibiotics, which may have to be fortified, are sufficient. But if it's blebitis with hypopia and intraocular inflammation, you may have to do an AC tap and give the appropriate antibiotic. Vancomycin, ceftazidime are usually quite effective. But if it's blebitis with endophthalmitis, with vitreous exudates, then vitreoretinal surgery is required, vitrectomy with intravitreal injections, and systemic antibiotics. So in conclusion, meticulous attention to detail during the surgery, careful postoperative examination, prompt recognition, and appropriate treatment will help you a long way to avoid these vision-threatening complications. Thank you.
Thank you so much, ma'am.